then even if you are given an expensive toy, you're not going to pick it up. Then you can use chromoendoscopy. You may need non-magnifying scopes to, sort of look at those polyps. You can use, as I showed you, acetic chromoendoscopy for the Barrett's. So you can use dichromoendoscopy, even with white light endoscopy, to pick up lesions. So remember, whatever tool you have, exploit it to its maximum advantage. Do a good quality endoscopy. Sedate your patient. Have a clean field. Don't say, अच्छा दोपहर में कितने बजे खाया है? 2 बजे खाया है? ठीक है, आ जाओ, आज ही कर लेते हैं. वापस जाना है ना राजकोट? नहीं. Don't do that. Make sure that if you're doing an endoscopy, let it count. Have a patient who's fasting, sedate him, wash, and interrogate. Meticulously assess the mucosa for precancerous lesions. So there are well-defined guidelines as to how to do it. You know about the systematic screening protocol for the stomach. Kenshi Yao's, what areas to take, what pictures to take, and look at it. All of us know about it, but put it into practice. When you have a suspicious lesion, do an endoscopic interrogation. When you write a report, make a good description, the size, the morphology, the Paris classification. Where is the location? You can't write just ulcer seen in body. Next time you don't know which part of the body is, anterior wall, posterior wall, lesser curve, greater curve. Right? The best way is document it. If you take a good picture, that tells you don't have to write too many other things. Right? As I said, excellent documentation with pictures, and the way to do it is to get the lesion in the lower half. If this is your endoscopy screen, if you want to document a picture, make sure the lesion comes here. You can't have a lesion here and take a picture, right? Get it there. Turn your scope, make sure you use your knobs, get it there, and you get good quality pictures. And then, if appropriate, perform endotherapy. If you have the skills and the lesion needs it, do it. So today, I think as I said, the title was to raise the bar. Our endoscopy should reach a couple of notches higher than what we're doing. You have the skills, you have the intelligence. It's just what we need is application and motivation. That whatever you do well always will pay off for you and your patient. I think I'll just stop here and maybe we can talk about some things. Gujarat has got such excellent people doing endotherapy and advanced procedures that I think we should see more people doing good quality diagnostic work, because that's the first step to doing therapeutics. Maybe Nilay, what do you?
Yeah. Sir, would you like to take biopsy if you feel it's an hypoplastic polyp on LVI?
So I think ultimately it goes down to two issues. What are you planning to do about it? How skilled are you with your diagnosis? How confident are you with your diagnosis? Say in my unit, if it's a small lesion on the left colon, we don't, or we dissect and discard, we don't use it. But it's not uniform. I can't say that you can do it for all patients. Yeah, but certainly I will not use a hot snare. I'll do a cold snare polypectomy and come out. So those are things, because this question of discard thing there are medical legal implications. So that is something that you have to be careful. Even when you see a lesion that I showed you, you may not want to resect it first time, because you don't know whether with your skills you may perforate, you may have problems. So at least in the Indian context, you may want a biopsy. So what we do typically with these small lesions is take one biopsy. Just one biopsy in the center, and then come out, because then you, at least for documentation, you got a biopsy. And then you may then talk to the patient and say, okay, still looks suspicious, I think I'll resect it. My skills are good, I don't think you should have a problem. So that will depend on an individual endoscopy skill, what's the patient's rapport with you, how you are able to convince them. But you're right, I think it's a good idea to biopsy a lesion if you're not sure.
And how do you prepare the stomach for NBA? Like, do you use Cynosicon routinely or?
Yeah, that's a very good question. Certainly we have our patients fasting, no doubt about it. When I am referred a patient who's already got a suspicious lesion, right? I always use Cynosicon, and there's now something available in the market. Something is available. So you give it to them for half an hour before, make them drink, and then I wouldn't say that it's fantastic. I wouldn't say it's fantastic, but it's a little better than not using it. So but we use a lot of water during the thing, and I find the water pump that we all are now have access to, I think is very useful. And I would not hesitate to send a patient back and say, come back another day because there's food there, and I don't think I'm doing justice by giving you a report to this. Come back another day and I'll do it.
She's having a CA esophagus and 3 cycle of chemo and radio. So right now there was a lesion from 25 to 30 centimeter, and it was just inflammation, and somewhere there is one ulcer. So I think radiation also does neovascularization. So we'll be able to pick up, or still I need to take biopsy, because at that time I thought for biopsy to differentiate.
Two challenges for any of these advanced endoscopic procedures is the presence of ulceration, presence of inflammation, right? So even in the esophagus, if you have esophagitis and you're looking at the Barrett's, you can always overdiagnose things. So we always would treat them, heal the esophagitis, and reevaluate. If you have an ulcer, all your things can be extremely misleading. So again, treat the lesion. You could biopsy, especially if you're in the stomach or something, you could biopsy, right? But you cannot sort of optically make an accurate diagnosis.
Because whole oncologists said because they want to continue chemo or what, that was the purpose of doing an.
So optically, you may have problems, but you could biopsy.
That I do.
So with NBI, like how frequently you use chroma endoscopy, like acetic acid and ethylene fever injection?
See, acetic acid I like to use, especially in Barrett's, because it shortens my procedure big time. I don't know what Nilay feels you don't use. I use that. The other site where I use chromo is in the colon. IBD's screening, we use chromo. There's still a recommendation. If you look at the scenic guidelines as well, it brings out the texture much better. That's what we're looking at. The third, which I don't have access to, is crystal violet, which is again a recommendation. If you have a 2B lesion, then use crystal violet for chromoendoscopy. Otherwise, digital chromoendoscopy that we refer to all these NBI and blue light imaging and all that is almost as good.
Thank you very much, sir, for such a wonderful talk. For the next session, I would like to invite Dr. Nilay Mehta, sir, for his talk on the role of NBI in the treatment of early cancer. As such, sir doesn't require an introduction. Sir is the head of the department at the gastroenterology at the Zydus Hospital.
અહીંયાથી થઈ ગયું છે તારો આનું યુ હેવ ટુ ચેન્જ કમ્પ્યુટર ટુ ધ કમ્પ્યુટર સ્ક્રીન. અહીંયા થઈ ગયું છે. જોઈ લે. એ તેની ઓટોમેટિક કરે પહેલાં, એનાથી કંઈ ના થાય, તું ચેન્જ ના કરતો. ત્યાં નથી આવતું.